Hello, everyone. Welcome back from the break. As a part of today's program, we are so pleased to be able to bring you an innovation session. Of course, we are in the virtual environment, and in lieu of a traditional poster session, what we did was issue a call for abstracts, and we'll now be presenting a handful of videos of the submitted abstracts that were selected as the top submissions. Several months ago, we invited individuals, teams, and organizations to submit abstracts showcasing innovative programs, initiatives, strategies, research, or products that could be at any stage within the development lifecycle, but had the aim of reducing stigma of people who use drugs. We received nearly 100 submissions from across the country. All the submissions that met the requirement criteria are included in a compendium, which includes the full abstract along with contact information for the authors. We hope this compendium can be used as a resource that fosters connection and collaboration on a range of promising stigma initiatives and can ultimately help build a stronger and broader network among those who are working to reduce the stigma of addiction. You can access the compendium on the right-hand side of our event page, and we encourage you to make use of this compendium. Today, we'll be featuring the top 6 submissions in video form, and those featured videos are listed here on the screen. Congratulations to everyone who was involved in these submissions. The initiatives that are featured here span regions across the US. We have initiatives specifically focused on reducing stigma within marginalized populations, and strategies that include everything from a media campaign to developing a primary care clinic curriculum and everything in between. We're so pleased to be able to share these innovative initiatives with you. So let's go ahead and roll the tape and you can learn more about these programs.
Project Echo is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge.
There has been tremendous effort across the state of Arizona to increase the number of buprenorphine waivered providers. And if this was the goal to simply get providers waivered, these programs would have been deemed quite successful. However, despite these efforts, the reality was that very few, about 3%, were actually integrating MAT into their practices. And in looking at why this was, a self-perceived lack of knowledge and confidence in MAT best practices persisted, coupled with an ongoing stigma around OUD and OUD patients. In response, our team here at Arizona State University gathered an interdisciplinary team of specialists in MAT. These experts represent prescribing physicians, a pharmacist, a policy expert, and a harm reduction specialist. Together, this team built and launched our medication-assisted treatment ECHO.
We've been very pleased with the outcomes of the MAT program so far. We've had robust participation and engagement from the community. Nearly 300 learners have joined since we launched, and an average of just under 50 learners join each session. As you can see from these heat maps, our learners are spread across the state, with some learners joining from out of state. They come from rural and metro areas and practice in opioid treatment programs, office-based opioid treatment programs, hospitals, and tribal clinics. Our audience has been very interdisciplinary, including healthcare providers, behavioral health providers, peer support, administrators, and other professionals. This has made for a really rich discussion of the patient cases. We assess learner outcomes through post-session and biannual surveys. So far, these surveys have indicated high rates of satisfaction with the program. Our average satisfaction rating is 4.6 out of 5, with most participants reporting they're extremely satisfied. Participants have also reported improvements in their knowledge of opioid treatment after participating in ECHO, including general knowledge of the treatment of opioid use disorder, knowledge about medications to treat opioid use disorder, and knowledge about related treatment modalities. Similarly, participants have reported improvements in their confidence across a number of domains, from starting a conversation about opioid use disorder with a patient to assessing for buprenorphine contraindications. This side-by-side graph shows the percentage of learners who reported they were very or extremely comfortable with these domains both before and after ECHO. And as you can see, participants reported improvements in all confidence domains. As a whole, we found high learner satisfaction and improvements in learner knowledge and self-efficacy in providing opioid treatment using this ECHO model.
One of the key elements to expanding access to buprenorphine and methadone is understanding that people who are living with substance use disorder are survivors. All too often they are blamed and treated as criminals. Stigma, as we know, is alive and well, both for the patient and for the provider. So one of the things we really want to do at the ASU MAT ECHO is to give the backstory, right, to understand that folks have survived trauma, that they have high adverse childhood experience scores, and then it took a lot of courage just to even show up to the prescriber or provider's office to seek help. When we're curious about people's stories, and when we understand that substance use disorder is a complex biopsychosocial phenomenon, then we can meet people where they're at. We can walk alongside them and witness as they struggle and try to make positive change in their life. And we can kick up the love a notch.
Echo! Yay, yay, yay! Good job!
Marhaba, my name is Mona Abdullah Hijazi and I will be presenting our study, Public Health Stigma Towards Substance Use. If you're wondering what I said in the beginning of the video, it was hello in Arabic, commonly used in Lebanon and surrounding countries. The reason I greeted you in Arabic is because our project is in the Arab American community. Before I describe the project, I will explain that the project is a collaboration between a large multi-service agency in metropolitan Detroit called Access, or the Arab Community Center for Economic and Social Services, in Wayne State University. I am a community engagement manager at Access for a federally funded community coalition promoting prevention on substance use and a PI for this project. The other PI is Dr. Cynthia Arfkin, a professor at Wayne State University who has conducted extensive research on substance use in the Arab American community. We also have team members of Hala Mallah and Ahmed Balut who we want to acknowledge. We cannot do this research without everyone on our wonderful team. Substance use is a problem in the Arab American communities, like all communities. The community traces their heritage to countries in the Middle East and North Africa. The countries share Arabic as the language and culture that emphasizes the group as opposed to individual. People from Iran, Afghanistan, and Pakistan are not Arabs as they have different languages and different cultures. Similar to these cultures, substance use and misuse are stigmatized. The use and misuse can bring shame to an Arab American family. The community reinforces shame through public stigma towards those who use and misuse substances. The community is diverse with people migrating at different times and different reasons. Major areas of settlement include Michigan, New York, and California. In Dr. Arfkin's work, she documented the differences in willingness to discuss substance use in the community by people born here compared to immigrants, by gender and by religion. By religion, we mean the two major religions in the Arab world, which is Christianity and Islam. In my prevention work, I have personally seen how people do not want to talk about substance use, or if they do, it is stigmatized those who do so. The stigma is a barrier to our coalition's prevention work. Locally, alcohol and drug overdose deaths are increasing among Arab Americans while declining among whites, emphasizing we need to expand our research. Our substance use advocate Ahmed Balut works with our local police department to provide treatment options to care for individuals who have run-ins with the law. The goal of this program is to provide medical care for individuals with mental health and substance use. Ms. Mallah has an expert in health education who helps with prevention activities in schools. So what is our project? We want to develop a reliable and valid scale measuring public stigma towards substance use in the Arab American community. We then will use this scale to measure stigma, components of it, in the next phase of our project, hopefully measure its reduction from our prevention measures. We have established a diverse and national expert panel of Arab Americans at universities who are knowledgeable about research and substance use. The panel includes women and men, immigrants and U.S.-born, and Christians and Muslims. Our local team reviewed the published literature of public stigma and modified its items to use for the Arab American community. We added a few items to reflect religious perspectives that were missing from the literature. An example of modified item is, in my community, most people would be willing to marry someone who has been treated for substance use. We then sent the 50 items to our panel for the review. We asked them if the domains were missing and how useful the items were for the community. The next step, reduced the numbers of items with positive scores to 19. Currently, we are conducting interviews in our community. We want to know if the items were understandable, and if so, their responses. We are using quota sampling to make sure that we have data by gender, religion, and nationality. With these data, we will refine the scale. With the new scale, we will survey the community to obtain internal consistency and independent sample and familiarity data and retest reliability. It was work in progress, and we thank our organizations for allowing us to present what we believe is important work to reduce stigma, promote prevention and outreach, and lower the burden of substance problems in the Arab American community. If you have any questions, please contact me, Mona Hjeze, at mhjeze@accesscommunity.org, or Dr. Cynthia Arfkin at cynthia.arfkin@wayne.edu. Thank you.
I'm author and journalist Maya Solovitz, and I co-founded Changing the Narrative because I got tired of the media being a conduit for misinformation. Most people get their information about addiction from the media, but many journalists don't know about the racist history of our drug laws or their unscientific nature. They think that the overdose crisis was driven by pain patients getting addicted, when in fact, most people who became addicted got their drugs from friends or family members. They think that exposure alone causes addiction and that it can happen in an instant. They think that addiction can turn ordinary folks into criminal zombies. If we actually want to destigmatize addiction, the public needs to know what it really is and how it happens. And in order to teach the public, we've got to first educate journalists to do better. And that's what we hope to do with Changing the Narrative. Thank you.
I got involved with Changing the Narrative because I'm a Black woman in recovery from substance use disorder. And I know all too well that stigma is a form of oppression. So language can either perpetuate it or it can educate to eliminate that kind of oppression.
I got involved with Changing the Narrative because as a writer and journalist, I believe in the power of language to shape our world. For decades, the media has labeled people who use drugs as addicts and drug abusers. But research shows that this language elicits negative attitudes, harsh judgments, and it even impacts people's health care. Humanizing people who have long been dehumanized is one of the founding principles of Changing the Narrative. In practice, this is actually quite simple, and everyone should be doing it. Instead of relying on outdated, stigmatizing language, we simply refer to people as people first. No one should be defined by their behaviors that stem from a mental illness. In working together, we've been able to tell more empathetic stories that truly change the way people think.
I'm here to talk about why we need to change the narrative when it comes to talking about drug use and addiction. We are in the midst of a massive public health crisis, the drug overdose crisis, which is predicted to have claimed more than 90,000 lives in the past 12 months. This has been driven by failed policy and inadequate access to effective treatment and effective care, largely driven by stigma and misunderstanding about drug use and addiction. During the time of COVID, we've seen overdose death rates surge. We've seen worsening racial disparities with rising rates of overdose deaths amongst Black and Latinx Americans. And we've been reminded of the health harms of living in a racist society. When it comes to drug policy and addiction treatment, policies in our country related to drug use have always been fueled by discrimination and by racism. It's time to change that narrative and to educate people about what works and what's effective. As evidence of how the narrative has malformed access to effective care, we've long known that medications like methadone and buprenorphine for opioid use disorder reduce the risk of death by more than 50%, and yet our policies limit access to care, and nearly 50% of U.S. counties don't have a single provider who can offer these medications. We continue to let myth and misunderstanding about drug use and addiction fuel our clinical care and the way we approach people who use drugs. Common myths and misunderstandings include the notion that all people who use certain types of drugs will develop addiction. For example, people who use opioids or cocaine as opposed to more socially sanctioned drugs like alcohol, or that tough love, treating people poorly, being hard on them, will actually help people get better. Or that being kind or compassionate to a loved one or someone with addiction or a substance use disorder is actually enabling them or causing harm. We need to undo these harmful myths and let science and compassion guide our approaches. Through changing the narrative, we hope to challenge some of the most common myths and tropes about drug use and addiction to better inform the public, policymakers, clinicians, people working in the healthcare space, people working in law, policy, public health, and to generally change the way we think about and care for people who use drugs.
Just about everyone agrees that stigma is one of the biggest causes of continued growth in overdose rates and rates of addiction in America. But one of the blind spots is that the very point of criminal law is to stigmatize. So the continued criminalization of people who use drugs is a huge barrier to better policies and programming to prevent overdoses and improve treatment. That's why we fight to decriminalize drugs and decriminalize people who use drugs.
Launched in 2019, Together in Recovery is designed to foster an accessible, integrated treatment and recovery network in Massachusetts that champions evidence-based approaches, supports multiple pathways to recovery, and puts people in charge of their treatment choices. After conducting convenings all across the state, it was very clear that finding accessible, accurate information about treatment and recovery supports was a challenge. And an even bigger challenge was finding information about the rights and protections for people with opioid use disorder. And that's why we decided to produce the Know Your Rights Toolkit. Together in Recovery is led by an advisory committee of diverse influencers, and they helped us design the toolkit and provided subject matter expertise on the content.
So when we click here and we go into the toolkit, you'll see the landing page. So this landing page right here really just provides that grounding that I just provided for you. But one thing I really do want to elevate here is this equity statement that RISE really recognizes the trauma, inequities, and violence that structural racism has caused for BIPOC communities and people in long-term recovery or any type of recovery. There are lots of barriers that exist to getting the help that folks want, and this toolkit recognizes those, tries to highlight that, and also work to create the foundation so that folks are able to get that treatment without those barriers and create that world where discrimination associated with drug use is over. So to go through each of the sections broadly, there's this navigation bar on the left-hand side, and these are all the sections that you can find more information on, rights and advocacy, and resources. So for example, if I go to treatment and recovery pathways, you'll see here that broad statement that there's no right way to recover. Again, your recovery is your choice and you are the driver in that journey. And this toolkit really does aim to help build that and empower folks to choose what works for them by not only giving them the knowledge, but also the rights that they hold so they can actively exercise their rights in all areas. So here under clinical pathways, for example, what I can do, I can open this and it takes me to all different types of services for clinical pathways for opioid use disorder.
This is a big deal. This is huge for our families and impacting people. I don't know about you guys, but I wish there was a toolbox when I was going through my process, because I know my parents and my mom couldn't figure it out. And I wanted to know, everybody wanted to know why, how can we help? How can we be involved? So I'm super excited about this toolbox.
The Know Your Rights in Recovery Toolkit is going to help build the foundation that we need as we go forward. It's going to help people seeking services and seeking support networks. It's also going to be a resource to educate, those who may be on the front lines providing some of those services. And so, we want to celebrate this important, concrete step forward in promoting health equity for all, especially for this vulnerable population. And I really appreciate it because it is putting the person who is struggling with addiction back at the center of the conversation about their care.
Hello and welcome to our presentation entitled Ending Self-Stigma for Justice-Involved Populations Being Treated with Medications for Opioid Use Disorder. I'm Shannon Wynn Mitchell, a senior research scientist at Friends Research Institute in Baltimore, Maryland.
And I'm Alicia Luckstead, a research investigator at the University of Maryland School of Medicine. Generally, in trying to reduce the harms caused by the stigmatization of any number of health conditions and other social identities, it's useful to break stigma down into several facets. In this case, societal stigmatization refers to the broad messages, disrespect, and discrimination that is unfortunately commonly aimed at certain subgroups by society. And in this intervention that we're developing, we're going to specifically address the anticipated stigma, which is the anticipation of societal stigma, and the internalized stigma, which is people taking in the societal messages that has really corrosive effects on their well-being, their motivations, and their self-concept.
One of the most overtly stigmatized groups in U.S. society are people involved in the justice system who face discrimination in everything from employment and housing to the attainment of student loans. While it's estimated that approximately half or more of the people involved in the justice system are experiencing substance use disorders, there are few interventions directly targeting this group. Substance use disorder is a chronic health illness, but is not treated the same way that as other chronic health issues, with people with substance use disorder often being blamed for having the illness itself. One of the most effective treatments for opioid use disorder are medications such as methadone, buprenorphine, and naltrexone. Unfortunately, even the use of these medications is often stigmatized, and people who take them are being treated and labeled as unclean, as if they're not in recovery.
Because there are not tested interventions that address the stigmatization of this population, in our work, we're starting with Ending Self-Stigma, a program that my team created to help people with serious mental illnesses navigate the effects that stigmatization can have of that condition. It's particularly focusing on anticipated and internalized stigma. On the left, you see some of the inputs for ending self-stigma: academic research, clinical experience, lived experience, and several conceptual models, which we then consolidate into 7 practical strategies that people can learn in a weekly psychoeducation and skill building class that is both manualized and interactive and personalized.
So the grant proposal that Alicia and I currently have under consideration at NIDA is to modify the Ending Self-Stigma program, specifically tailoring it to justice-involved people with opioid use disorder who are considering treatment or using medications as part of their treatment. The first part of the ESS modification process involves a systematic literature review and some stakeholder and focus groups to refine the ESS intervention to specifically target the stigma for this population. We'll then conduct 2 iterative rapid pilot tests of this modified ending self-stigma intervention, and further modify each of the ESS MJP sessions based on the flow of the intervention and the feedback we receive from the participants as well as the facilitator. Ultimately, we hope to finalize this refined ESS MJP intervention and the materials to be used for it for a future efficacy trial.
In the end, we anticipate we'll be able to both retain the core principles and lessons of the original ESS, which has made it quite effective, as well as tailor the details of content and delivery to the particular situation and stigma dynamics of this particular population. So we anticipate that we will end up with a intervention that is both practical to deliver and useful for the participants in reducing the harms of internalized and anticipated stigma so as to help them engage with and stay with treatment, as well as enhancing their overall resilience and recovery.
Thank you so much for your time. Please contact us directly if you have questions or recommendations.
Thanks.
Hi, and welcome to our presentation, Collaborating with Community Partners to Develop a Harm Reduction and Stigma Curriculum. My name is Sandra, a primary care provider in the San Francisco Health Network and curricular lead for this project.
I'm Jerry, and I'm a first-year medical student at UCSF.
Hi, I'm John.
And I'm Sad.
And we're health educators with the Syringe Access Services Department here at the San Francisco AIDS Foundation.
We'll be your presenters today, and also wanted to highlight some other key members of our team, shown here. By now, many people are familiar with the opioid epidemic. Over the last few years, there have been sharp increases in mortality from drug overdoses across the nation, driven by the introduction of fentanyl into the drug supply and made worse by the COVID-19 pandemic. In 2019, 441 people died of drug overdose in San Francisco. This number rose to 700 deaths in 2020 and continues to rise rapidly. In response, a pilot was launched where community primary care clinics were identified as sites to distribute intranasal naloxone and safer consumption supplies to at-risk patients, with the goal of preventing overdose deaths, increasing safety around substance use, and access to harm reduction services. Our project aimed to develop a training curriculum that would educate providers and serve as a foundation for these pivotal patient interactions. When we were initially developing the training, we were focused on thinking about how frontline staff could be trained on how to use intranasal Narcan and the safer consumption kits. However, our community partners at the SF AIDS Foundation, with their experience in serving the community and their own lived experiences, said, that's the easy part, to teach that stuff. What's hard is addressing the main barrier for people who use substances, and that's stigma. And stigma starts way before the clinic encounter. It starts in the waiting room, at the front desk, with the environment. Then there's stigma from others, clinic staff, providers, and then there's self-stigma or internalized stigma. And all of this serves to keep people away. And there's no point in having all these supplies and services if your patients can't access them. We need to address stigma. So we developed a training with 3 components, with the harm reduction and addressing stigma session as the foundation, followed by an overdose prevention and intranasal naloxone module, and videos created by the SF AIDS Foundation reviewing the safer consumption kits. One thing that was important to us was including the voices of people with lived experiences as experts in their own care, both in the development of the curriculum and through the power of sharing their stories. The Harm Reduction and Addressing Stigma session is a guided discussion-based session that is conducted at each pilot clinic site. We talk about basic harm reduction principles, the effects of stigma, and how we can address it. We also learn and hear from our community members who share their experiences with stigma and harm reduction. The training provides a safe and protected space to start a conversation that we hope will continue long after the training. Before the training, we meet with each clinic site champion beforehand to discuss the specific educational needs for their clinic, and then tailor the training accordingly.
About our overdose prevention or Narcan module, it was built using Google Forms with material provided by our collaborators at the Joe Project, supplemented by video narratives and interviews shared by our community partners at the SF AIDS Foundation with lived experiences of responding to an overdose. The module is super interactive with questions scattered throughout it, and it's pretty simple in terms of its learning objectives. It goes over how naloxone works, when to use it, or in other words, how to identify an opioid overdose and how that's different from being high, and how to respond to that overdose in a way that's really trauma-informed. So using the Narcan, calling the emergency services, etc.
We recorded these videos on safe consumption kits and fentanyl test strips to explain supplies and how to use them.
We asked other health educators with the Syringe Access Services Department here at the San Francisco AIDS Foundation to record these videos. These videos are designed to educate providers and other clinical staff on substance use and harm reduction to break the barriers to stigma so that substance use can be talked about openly and honestly between patients and clinicians in clinical settings and improve health outcomes for all involved.
In terms of evaluating the effectiveness of our harm reduction and stigma training, before the training, we have participants complete a survey that tells us to what extent they interact with people who use drugs, as well as their levels of drug-related stigma. Post-training, we assess changes in that drug-related stigma, as well as changes in people's perceptions and practices around harm reduction. That's all we got for now. Thanks so much.
I hope you found those videos to be informative. Again, congratulations to those who were selected to be featured today. And thank you again to everyone who submitted an abstract. For more information, please refer to our compendium, which can be found online on our website,